Couple more folks. Great. Okay, well, welcome everyone. My name is Amy Harris, and I'm the manager of the Patient-Centered Primary Care Home Program. And I'm really glad you're joining us today for this webinar, which is part of our series to help practices prepare for the 2025 standards, which will be implemented in January. So this particular webinar is on PCPCH Standard 4B, which is Medication Reconciliation and Management. And I'm going to turn it over to my colleagues today who are going to talk with you about the standard. And then at the end, we'll have lots of time for your questions or your comments or anything that you want to share about this measure or standard at the end. So I'm going to turn it over to Laura Lee and Amber.
Thanks, Amy. Good afternoon, everyone. My name is Amber Anderson, and I'm an improvement specialist with the Patient-Centered Primary Care Home Program. Today, we're going to talk about Standard 4B, Medication Reconciliation and Management. So just a few webinar logistics and Zoom etiquette reminders. The webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization information up. Any questions or comments that you have can be put in the chat, and we will answer them during the questions session at the end of the webinar. Here's the agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we're going to do a deep dive into the PCPCH Standard 4B. Then we will share additional PCPCH resources and upcoming webinars. Lastly, we'll have some time for your questions. The PCPCH program was established in 2009 by the Oregon legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st of 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is available on our website. And I'll hand it over to Laura Lee.
Yeah, thanks, Amber. Good afternoon, everyone. I'm Laura Lee Trocio, and I am an improvement specialist with the Patient-Centered Primary Care Home Program. Today, I'm going to review the PCPCH Standard 4B, which is about medication reconciliation and management. Under the current model, this is listed under 4G. So this is not a new standard, it's just numbered differently within the 2025 model. PCPCH has 6 core attributes, and Standard 4B is under the core attribute continuity, which means providers knowing their patients and working with them to improve their health over time. Or from a patient's perspective, be our partner over time in caring for us. The intent of Standard 4B is to address evidence that significant health problems are caused in part by medication errors. Medication reconciliation and management can be important components of a comprehensive approach to preventing such errors. They are also critical components of care transitions for complex patients and effective care for patients with complex or high-risk medical concerns. Slide 6. The standard 4B, it is not a must-pass measure. In the new model, it will change from a progressive standard, so choosing only one measure level, to check all that apply to your practice. In other words, practices optionally choose which measures describe their clinic. 4B2 is worth 10 points. This is when a PCPCH provides medication reconciliation for its patients. 4B3 is worth 15 points, and this is when a PCPCH provides comprehensive medication management for its patients by a pharmacist. A practice may receive the maximum of 25 points if both measures are applied to and verified. Next slide for Amber.
Thanks, Laura. Now let's take a look into measure 4B2. In the current 2020 standards, this measure has a requirement around performing medication reconciliation only for those selected patients with complex medical concerns rather than the whole patient population. This has been updated in the new 2025 standards to include all patients. However, there is a new requirement in the 2025 standards in the specifications regarding which healthcare professionals should be performing each step of a comprehensive medication reconciliation. The practice is meeting measure 4B2 if it provides medication reconciliation for all its patients or for its patients with complex or high-risk medication concerns. The practice's medication reconciliation process must include all of the following elements. First, the practice's medical assistant, nurse, provider, or other care team member identifies all medications a patient is currently taking, including name, dosage, and frequency. The medication list should be developed by comparing the medical record to an external list of medications obtained from a patient, hospital, or other provider. If the medication list was identified by an MA, nurse, or other care team member, there is a process in place for communicating any medication changes to the provider for their review and assessment. And lastly, the provider conducts a medication reconciliation by reviewing the medication list and any identified changes with the patient to assess any challenges in obtaining or taking the medication, assesses appropriateness as a treatment based on the patient's current condition, assesses the patient's understanding of how and why they are taking the medication, and ensure the medication list is updated appropriately. So here are a few examples of how measure 4B2 can be implemented in your practice. A patient is in clinic for a hospital discharge follow-up visit. The practice's medical assistant has been trained by the provider on how to identify the most accurate list of medications a patient is currently taking and reviews the patient's discharge summary. If there are any changes in the patient's medications, the medical assistant notifies the provider, and then the provider has a conversation with the patient about the changes to their prescriptions or other medications. Another example would be the practice instructs their patients to bring all of their medications that they're taking to their appointments, including any over-the-counter or herbal medications. The practice's medical assistant documents this into the medication list in the chart. The list is then reviewed by the provider with the patient and family members as part of the patient's visit, and they determine if any changes are needing to be made. As you're completing your PCPCH application, we strongly recommend you gather and collect all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program staff to demonstrate that you're meeting the requirements of the measure. For measure 4B2, here are some examples of what you would need to provide for the documentation requirements. A policy, procedure, or workflow that demonstrate how the practice completes medication reconciliation for patients. And we would also like to see chart note examples of that medication reconciliation for patients that includes that engagement with their provider. And now I'm going to hand it back over to Laura to go over measure 4B3.
Thanks, Amber. A practice is meeting 4B3 if it has a pharmacist who works with the care team and performs the following types of functions for patients identified as having complex or high-risk medication concerns. The pharmacist meets with patients, families, or caregivers to obtain and document a complete medication history. They review medical records and assess patients' clinical status to ensure medications are appropriate, effective, and safe. They develop and implement a plan of care in partnership with patients and their care team. They plan follow-up evaluation and medication monitoring that includes assessments of patients' progress towards the treatment goals. And they are available for patient appointments and warm handoffs when complex or high-risk medication concerns arise. These services should be available for enough hours each week to adequately address the needs of the patient population. The pharmacist can provide services by telehealth as long as they meet all of the requirements listed above. A practice cannot attest to this measure if these services are only offered for provider consultation and the pharmacist does not meet with the patients. Slide 12, please. Examples of 4B3 include a pharmacist collaborates with primary care providers and other care team members to improve the health of patients who are prescribed multiple medications. The pharmacist works to provide collaborative drug therapy management services, assist medical personnel and patients with drug information and identification, develop and sustain patient relationships, and evaluate and resolve identified drug therapy problems that are identified. They also work with patients to obtain information regarding drug use, drug allergies or sensitivities, and document the information in the patient's chart. Additionally, they are able to meet with patients either in person or by telehealth for appointments and are available for warm handoffs when complex or high-risk medication concerns arise. Another example is a pharmacist uses a risk stratification system to reach out and set up telehealth visits with each of the practice's high-risk patients with diabetes at least once a year to review their medications and assess for effectiveness, safety, and adherence. The EHR medication list is adjusted and the provider is engaged if appropriate. Next slide, please. As you are completing your PCPCH application, we strongly recommend that you gather and collect all documentation that would be needed for a site visit. During the site visit process, you would be required to show the following documentation to the PCPCH program team to demonstrate you are meeting the measures. For measures 4B3, here are some examples of what you would need. A schedule, template, or other document showing the hours and/or days the pharmacist is available to the patients. Chart notes examples of comprehensive medication management plans that are in partnership with the patients. They must include the following elements: medication reconciliation during office visits and transitions of care, clear communication of desired clinical outcomes for each medication in use, monitoring of progress towards desired clinical outcomes, review and discussion of therapeutic goals with the patients and the care team, and plan follow-up intervals with the patient. Next slide for Amber.
Thank you, Laura. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the new standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed here on this slide. I hope you'll be able to join us, but the webinars are recorded and will be posted on our website if you can't make it. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. Here you can find anything PCPCH related. The second is our 2025 TA guide with detailed information about how to implement every new measure and the documentation requirements. Next is the link to our TA resource webpage. And lastly is our community engagement report and evaluation. Lastly, you're always welcome to reach out to the PCPCH program with any questions through our program email. So this concludes our webinar on Standard 4B. Thank you so much for joining us. Now we'll go through some of your questions. It looks like we have a couple in the chat.
Great. Thanks, Amber and Laura Lee, so much. That was a really great presentation and a good overview of the standards and the requirements. So we do have some questions in the chat, which is great. So I'm going to ask Susan if you wouldn't mind, perfect, unsharing your screen so that we can see each other if folks want to turn their cameras on or unmute themselves during the discussion period. Okay, so let me scoot up to the first question. So it looks like there's a question about 4B, and the question is, please clarify, is it permissible if MedRec is completed for complex patients only and not for all patients? Standard 4B2 indicates all patients or complex patients. That's correct. It could be done for either or. So what we found when our site visitors were doing site visits is that many clinics were doing it for all of their patients, even though the measure requirement in our most current set of standards only requires it for complex patients. We found that many practices were doing the same medication reconciliation for all their patients, so we expanded it. So in addition to making it either only your complex patients or all your patients, the other big change in the standard is the structure. So if you think back to what Amber reviewed, and you can also read it in the TA guide, it's really, it has to include all those components that we discussed. But again, it could be just for your complex patients or all your patients. It's really up to you as a practice, which makes the most sense for your patient population. That's a good question. There's another question also about if it's a visit for only medication reconciliation, how is it coded for billing? I don't think that's a question our team on the PCPCH side can answer. We're not really familiar with medical billing enough to be able to answer that question. But I would say if there's anyone on this call who might know how you would bill for that call or bill for that type of visit, if it's MedRec only, or if that's even possible, you could drop it in the chat if you know that billing code, or you could also just unmute yourself and speak up. So I'll just see if anybody, I'll just pause here for a second and see if anybody knows the answer to that question.
And I'll also just add, we're not asking for clinics to do medication only appointments or medication reconciliation only appointments. It's that the medication reconciliation is done as part of their appointment.
Mm-hmm. Yep, that's a good clarification, Amber. I appreciate that. Okay, well, I don't see anybody chiming in with that answer. So I would say, you could certainly talk with your billing provider, or whoever does the billing in your office, or reach out to your to whatever provider or whatever payers you most frequently contract with. So reach out to your CCO, reach out to the commercial payers that you contract with, and see if that's something, what type of billing code you might use for that, if possible. So the next question is around pharmacists. So I'm assuming for 43. Pharmacist, minimal requirement of hours per week or can meet with patients as needed. I'm not sure I understand that question, but I can go to the second part, which is how is the pharmacist paid? And would it be possible for OHA to hire pharmacy staff for a small clinic to access when needed? So pharmacists are paid by the practice. It's not something that OHA pays the pharmacist. We don't pay the pharmacist. You can actually contract with pharmacists as well. So we have some practices that will use like a telehealth pharmacist, which is fine as long as the pharmacist is actually meeting with the patients. So again, that would be something that the practice would pay for. You can certainly, we can certainly think about connecting you with other practices if you want to reach out to us offline. If you're wondering how other practices might pay for that or who they're working with, we can actually try to put you in touch with other small practices to see who might have a pharmacist, to see how that service is being provided for their patients. I'm still not sure I understand the first part of the question, which is minimum requirements per week. I don't know if
Sure. My question is, do I have to have a designated number of hours per week for the pharmacist, or can that pharmacist be as needed? So maybe this week I don't have a need for a pharmacist. Next week I might need 3 hours, then nothing for the next 2 weeks, that kind of unneeded schedule. Thank you.
yeah, so we don't specify, I appreciate you clarifying that, that's helpful. So we don't specify in the requirement or in the technical specifications, minimum number of hours or anything like that, because we know that each practice is a little bit different. They're all different. So I would say, whatever is meeting your patient population needs, and as long as you're following the requirements, the other requirements that are in the technical specifications. I know our site visitors, I'll see if any of our site visitors want to comment or provide additional information about what you've seen in practices who are using pharmacists in that way. I see, Amber, you're nodding your head. I don't know if that means
honestly, I've been a site visitor for 7 years, and I don't honestly think I've seen where somebody has kind of an as needed schedule, or though we've heard about that. Typically it's a scheduled, like they're there every Thursday or every other Thursday or 3 days a week. And they have a set schedule and template so that not only the staff in the clinic know when they're going to be there. If they do have a complex patient pop up, they'll know, oh, so-and-so is here today, or no, she's not in until tomorrow. So not only your staff know when to expect them and know they're there, but your patients as well, who are working with the pharmacist. So I don't know. I think it would probably be one of those situations where we'd have to really see what you're providing for documentation and talk with your staff at a site visit, if it was verifiable or not.
I
But
can
we
add
also,
to that, Amber.
yeah,
Oh, go ahead.
I was
Yeah,
just gonna
okay.
say, we also hear staff monitoring their own usage of their pharmacist. If they themselves are seeing, gosh, our pharmacist is booked out 3 weeks and we can't get patients into them and we're not having them available for warm handoffs, and that's when we need to reassess how often that person's in the clinic.
Yeah, and I can add to that as well. So say, for example, there's a practice that has identified patients who have diabetes, so their pharmacist meets with diabetic patients, as long as, or whatever complex or high risk medication population that they've identified with, as long as those patients also have the opportunity to sufficiently meet with pharmacists. So they're not being kind of like shortchanged of available appointments, and that their needs are being met by the availability of the pharmacist's schedule. So hopefully that's helpful.
That's a good question. And as I mentioned, since you've asked all three of those questions, we'd be happy to talk with you offline or perhaps connect you with another practice. Just reach out to us. We'd be happy to give you some extra support around that. So the next question is, can you also clarify the first specification on 4B2 in regards to alternative traditional vitamins or nutritional supplements? It's extremely time consuming to enter supplements, doses, and frequencies, and they can change frequently. Is it expected that these are reviewed at every office visit and added with every patient, or just the medically complex patients, or is it up to the discretion of the clinic? So this part of the measure is unchanged. We've always recommended that practices look at additional things that might have interactions with prescription medications. With regards to what you should be including, I really think that that's a question that the provider should be talking with you about, and maybe if you have a pharmacist who could help you with that. And then with regards to when it should be added, if it should just be for your complex patients, if you are doing the medication reconciliation for all of your patients, you should also probably be doing that check for all of your patients as well. So it really depends on, are you doing medication reconciliation for just your complex patients, or are you doing it for all of your patients? If you're doing it for all your patients, then you really should also be considering those additional types of medications or over-the-counter types of supplements that patients might be taking. But we're not going to necessarily go through and say, okay, do you have all their vitamins written down? Do you have all those things written down? It really is up to the practice to decide what you want to include in that. So I don't know if our staff, if our site visitors have anything to add around that.
I mean, I think that if they're working with a pharmacist and there are medication therapy regimens or goals, and some of those supplements are part of meeting those goals that they are working with a pharmacist, then it does affect their medical well-being, then you may want to think about including some of those other supplements and vitamins and things like that. So like Amy said, you may want to consult the provider as far as like how important it is to include those supplements and or the pharmacist.
Great. Okay, so it looks like the next question, is there also a chart note example for 4B2 that helps outline what is being looked at in regard to provider medication reconciliation? Oh, so you mean, do we offer an exam? Are you asking if we're at, are you asking if we can provide a chart note example, or are you asking if we can provide an example of what's being looked at? I'm not sure I'm understanding that question.
I think she might be asking like what needs to be listed in a chart note to demonstrate that it's a provider medication reconciliation. I know in chart notes in the past, I've seen where the medication list is updated and it might even state like medication list updated, and you can see that in the chart note. You can see provider updated medication list written in a chart note. But that also goes kind of hand in hand with your policy. So if in your policy, it's written out how that medication reconciliation is done and how the patient is meeting up with the provider at the end, and then you're demonstrating that in a chart note somehow, that's kind of up to you and your EHR capabilities of how you would demonstrate that. It could be a dot phrase that's added maybe where it says provider has met with patient for medication reconciliation. It could be in a template, however you would want to do that in a chart note. I don't think that we need to see every single one of these elements written out in a chart note. I might ask any other site visitors if they have anything to add to that. Or if Jessica, if you want to unmute and if that's not what you meant by your question.
Yeah, just kind of mostly looking at, kind of the verbiage within a chart note that would be sufficient, or how it can, you know, I guess even a bad example would be a good one too. Just kind of for a little bit more guidance on what clinics should be looking to document for that purpose.
Yeah, like I said, I think we like to see the list of the medications, their dosage, their usage, like that being updated in the chart note, and us being able to somehow identify that that's been done, and that if there were any changes, that then the provider met with the patient. So again, how you'd want to document that in the chart is probably up to you and your EHR capabilities. A bad example might be, none of that information being in there, us scouring a chart note and not seeing any kind of even a checkbox or anything that discusses medications, dosage changes, or anything like that.
Thank you for that question, and thanks for the good answer, Amber. So there's another question. It says, many of the insurance companies we work with provide comprehensive medication management services based on risk scores, where they meet with the patient and provide our clinic a report. Then the provider will address as needed. Would this qualify, or does it need to be a clinic employed pharmacist? So that's a good question. So if you look at the specifications, so it could qualify. It really just depends on if the patient is meeting with the pharmacist that the insurance company is providing, and if that pharmacist is available to do things like help develop care plans, meet with the patient and their family, is really there for the patient, and is more of acts as more of a care team member in some ways, rather than just somebody who's working on behalf of the insurance company to ensure that that the patient is having their medications managed in a way that's most cost effective for the practice. So so it really depends. I think our team would want to see exactly what that relationship looked like, what kind of services were being provided, and who was actually providing them, in order for us to say whether it would meet the measure. So I don't know if the site visit teams, if you guys have encountered any of that before, if you have anything to add, or maybe you have verified that or not verified that in the past.
Thing I would add is that we want to make sure these services are available to any complex patients, regardless of the payer. So if you had an agreement with a payer that's doing this, but they're only doing it for their, that insurance, say Blue Cross, for example, and they're only doing it for your Blue Cross patients, then that wouldn't meet the need of all of your patients. So in that case, I don't think that would be anything we would verify. So, but as Amy said, it always kind of comes down to at a site visit, like what we see in the documentation, what we hear from your staff, how they describe your relationship with them. And one of the specifications is they develop and implement a plan of care in partnership with the patient and their care team. So if it's kind of a one-sided thing and they're just sending notes over, it doesn't seem like there's really that partnership. So again, we would have to hear about it at the site visit, and it could be, you never know.
Thanks for that question. Other questions? That's all we have in the chat. Other questions folks have?
I am still a little perplexed about the pharmacist on staff. I'm a solo clinic. So let's say I contract with a pharmacist for 2 hours a week, but that week I don't have a need for the pharmacist. I don't have any complex patients that I need to discuss or for the pharmacist to meet with. Just wondering how that would work, because I would be in an agreement of paying for that pharmacist, but may not necessarily need it in the small clinic scenario. Thank you.
Yeah, that's a good question. I mean, I think if you're contracting with a pharmacist for 2 hours a week, I think that's great. I think it would just depend on the arrangement that you had with a pharmacist. I mean, I think that, and kind of what that contract would be, meaning that is that pharmacist expecting payment for those 2 hours a week, regardless of whether they're seeing patients? Or are they willing to work sort of like as needed, meaning if they see patients then they get paid, but if they don't see patients then they don't get paid. So that would really be like an arrangement that would be between you and a pharmacist, or any provider actually that you were hiring and contracting with. And again, we'd be happy offline to connect you or see if we can reach out to any other smaller solo practices that are using pharmacy services, to see if we could give you some ideas or some resources to help you with that. We do know that practices that have pharmacists really find them beneficial, but we also know it can be a challenge sometimes for solo practices. So we definitely want to connect you with the resources that we have, and we can do a little digging around and see. So again, we'd be happy to again help you with that. So
thank you. That sounds really great.
Yeah.
Thanks.
Other questions folks have? Okay, well, I'm not seeing anything in the chat. No one's unmuted. So I just want to, again, remind everyone that you are welcome to reach out to the PCPCH program at any time. Rachel on who you can see on the screen here is the person behind our email inbox. And she answers all the questions. And if she doesn't know the answer, she reaches out to the rest of the team to get them for you. She's very prompt. And you can ask us any questions about the application process, questions about the standards, questions about the measures. And I really encourage you to do that if there's something that's on your mind or something you're unsure about, not just related to this particular standard, but related to any of the standards. We are happy to help and we want to support you as we move forward in thinking about how these standards and measures will be implemented. So please reach out. We're, again, happy to help. And I also hope that you'll join us for the other webinars that we have coming up for the rest of the year. And then also, if you've missed any, you can feel free, of course, go back and watch the recordings. The other thing we're also planning to do, probably toward the end of this year, we haven't set the schedule yet, and maybe the beginning of 2025, is to set up some open office hours. So if folks want to come and just ask questions, you don't want to reach out or you want to hear what other people say or other people's questions. I know sometimes people join office hours to hear other people's questions, which is also very helpful. We're going to be setting up some of those. So I hope you'll join us for those as well. We just want to be as helpful and resourceful as we can be as we move toward these new standards. So again, thank you everyone for your time today. Thank you for joining us. We'll be sending out a survey after this webinar. If you have any feedback for us on how we can improve these, if there's any additional information you want, please let us know on that survey as well. And we'd be happy to provide that for you. So again, thank you. Have a great weekend, everyone. And I'll see you next time. So.